Nutritional Management Angela K. Pham, Stephen A. McClave 6 Nutrition in specific disease states nutritional assessment and directed nutritional therapy are important in the treatment of many GI diseases. Familiarity with appropriate nutritional intervention is imperative to obtain good clinical outcomes. The preceding chapter reviewed nutritional assessment, and this chapter will give an overview of nutritional concerns in common GI disorders and treatment of nutritional deficiencies by parenteral nutrition, PN, and enteral nutrition, N. Intestinal failure, IF, describes a state of insufficient intestinal capacity to fulfill nutritional demands, resulting in dependency on the use of PN1, although the definition of IF has been revised by multiple sources. The European Society for Clinical Nutrition and Metabolism, ESPN, is the first scientific society to issue a formal definition for intestinal failure. In the ESPN definition, 2 criteria must be present: a decreased absorption of macronutrients and/or water and electrolytes due to a loss of gut function, and the need for parenteral support. 2 IF is further classified into types I, II, and III. Type I IF is acute, short-term, and due to a self-limiting condition such as ileus following abdominal surgery, which may require a brief period of nutritional support. 3 Type II IF results from a prolonged acute condition, often in metabolically unstable patients who require supplementation over periods of weeks or months, and may be reversible or irreversible. 3 Type II IF patients may recover fully or progress to Type III intestinal failure, which is a chronic state of IF requiring long-term nutritional support, typically in the form of home PN. 4 Etiologies include Crohn's disease, CD, see Chapter 115, radiation enteritis, see Chapter 41, intestinal obstruction, see Chapter 123, dysmotility, see Chapters 99, 100 and 124, intestinal trauma, congenital disorders, see Chapter 98, intestinal fistulae, see Chapters 29 and 115, and vascular complications, see Chapter 118.1 Short bowel syndrome, SBS, due to intestinal malabsorption associated with a functional small intestine length of less than 200 cm is a common cause of IF, see Chapter 106. After extensive intestinal resection, 3 clinical stages have been described. The first stage occurs during the first few weeks after resection and is characterized by significant fluid and electrolyte shifts that require copious amounts of fluids to prevent dehydration. During the second stage, which may last for up to 2 years, there is both structural adaptation, increase in size and absorptive surface as a result of cellular hyperplasia, and functional adaptation, slowing of bowel transit to allow increased time for absorption. The third stage is a stable phase during which no further improvement or adaptive changes occur. 5 Nutritional management of SBS depends on the amount and location of small intestine removed, because the intestine has the ability to adapt and increase its absorptive function over time. Initially, PPIs are used to reduce gastric hypersecretion, and anticholinergic agents and opioids are used to slow intestinal transit. Patients may require larger doses of anticholinergics than are usually recommended, because absorption of the oral medication may be limited. PN is prescribed during Stage 1 to meet nutritional needs. During Stage 2, oral feedings are gradually started, and the volume of PN is reduced as oral feedings are increasingly tolerated. Patients should eat small, frequent meals avoiding simple sugars, fiber, and nutrient-poor foods and separate the times of fluid and solid food ingestion. Lactose is usually well tolerated, unless the proximal jejunum is resected. Dietary intake should be increased by at least 50% because most stable adult SBS patients absorb only half to 2/3 as many calories as normal. Such a hyperphagic diet is best tolerated when consumed as 5 to 6 meals throughout the day. 6 Diarrhea may result from oral feedings and may limit weaning from PN. While percutaneous endoscopic gastrostomy, PEG, placement in the management of SBS is controversial, enteral tube feeding administered continuously over 12 to 24 hours is usually better tolerated than intermittent bolus feeding because of greater nutrient absorption and less osmotic diarrhea. N is usually slowly advanced while PN is isocalorically decreased over several months, with frequent monitoring of tolerance as determined by the development of symptoms, amounts of food and fluid intake, stool and urine output, body weight, hydration status, and micronutrient levels. 7 Following extensive resection of the small intestine, 3 distinct clinical types of SBS can be identified. In type I SBS, patients have only jejunum remaining with an end-jejunostomy and no colon. These patients experience massive fluid shifts, show little signs of adaptation over time, and are more likely to be PN dependent. In type 2 SBS, patients have variable length of jejunum connected in series with some portion of colon. Clinically they show greater signs of adaptation but demonstrate slow deterioration of nutritional status over time without parenteral support. Finally, in type 3 SBS, intestinal rehabilitation of the remaining small intestine is most likely to be successful, meaning the patient can resume intake of adequate oral nutrition, because the colon has been preserved and is in continuity with the small intestine and the ileocecal valve is maintained. 8 Production of glucagon-like peptide, GLP-1 by the remnant of terminal ileum has a trophic effect and stimulates SB adaptation, as a result of which these patients rarely need N or PN. Clinical factors useful in predicting the success of intestinal rehabilitation include the presence of residual disease in the remnant bowel, bowel length, the degree to which adaptation has occurred, and the duration of time on PN. Intestinal autonomy is defined by the ability of a SBS patient to live without PN and may be expected if a patient has 70 to 90 cm of small bowel and an intact colon, or 130 to 150 cm of small bowel with no colon. Through the period of adaptation, intestinal autonomy may be achieved more readily for calories than for fluid and electrolytes. Citrulline, a non-protein amino acid produced by intestinal mucosa, has been proposed as a predictor of permanent versus transient if. 6 In one study, a plasma citrulline level of below 20 mol/L identified patients destined to have permanent if, with positive and negative predictive values of 95% and 86%, respectively. 9 Patients with severe SBS, 200 cm small bowel remaining, usually require a glucose electrolyte oral rehydration solution, ORS. Ingestion of an ORS containing glucose with a sodium concentration of at least 90 mol/L aids in water absorption by making use of sodium glucose CO transporters in the jejunum, see Chapter 101. Between 2 and 3 L of an ORS solution should be sipped throughout the day. Hypoosmolar fluids should be avoided, as their absorption is dependent mostly on passive diffusion. Hyperosmolar fluids also should be avoided in patients with SBS, because they lead to fluid shifts into the bowel lumen, worsening diarrhea. 6 If a patient has had a partial ileal resection of 100 cm, and has an intact colon, the bile-binding resin cholestyramine can be used to reduce bile salt-induced diarrhea. In patients with a limited amount of ileum remaining, greater than 100 cm of ileum resected, and an intact colon, however, cholestyramine can increase diarrhea by depleting the bile salt pool. In general, fat restriction should not be used for SBS type I patients who do not have a colon, but it may be beneficial in reducing diarrhea for SBS types 2 and 3, in which some length of colon remains. 10 Even in these latter types, however, fat restriction may not change the volume of diarrhea, and polyphagia is made more difficult without the ingestion of calorically dense fatty foods. Vitamin B12 injections should be administered monthly if more than 50 to 60 cm of terminal ileum has been resected. The somatostatin analog octreotide has been shown to prolong small intestinal transit time and decrease GI secretions, but its use remains controversial because it is also associated with gallstone formation and decreased splanchnic protein synthesis, and has not been shown to eliminate the need for PN. 11-14 The use of growth hormone and glutamine to promote small intestinal mucosal hypertrophy and improve absorption is controversial. A single randomized controlled trial, RCT, demonstrated decreased PN volume, calories, and number of infusions with this approach, although the effects were short-lived, and measured parameters returned to baseline after cessation of therapy. 15,16 Use of a GLP-2 analog has been shown to be a trophic stimulator of small intestinal mucosa, resulting in improved absorption. Teduglutide, a GLP-2 analog, was shown in a RCT to significantly reduce the volume and number of days of PN for patients with intestinal failure, and resulted in weaning from PN dependency in a small percentage of patients. See Chapter 106. 17 Pancreatitis. Nutritional therapy in the management of acute pancreatitis, AP, has undergone a significant paradigm shift from previous practices. Historically, patients with AP were kept NPO to avoid the potential risk of further stimulating exocrine pancreatic secretion and worsening inflammation. Over the past 2 decades there has been a shift toward early N in AP patients, but also in all critically ill patients. Data on early feeding, initiated within 24 to 36 hours of admission, in AP have demonstrated lower risk of multi-organ failure, MOF, operative interventions, systemic infections, septic complications, and even mortality compared with what had been standard therapy, no N/PN, or delayed N.18. The Python, pancreatitis, very early compared with selective delayed start of enteral feeding, study, an RCT in which patients were allocated to receive N within 24 hours through a nasojejunal, New Jersey catheter or be given an on-demand oral diet over the first 4 days, and then only start N if the oral diet were not tolerated, seemed to refute these results. Outcomes showed that rates of major infection or death were no different between groups 19, although only 20% of patients in this study were admitted to the ICU, and less than 8% had severe AP, defined by persistent MOF 48 hours. The key issue in nutritional therapy is severity of the systemic inflammatory response syndrome, SIRS. If the SIRS response is severe enough to require admission to the ICU, especially if the patient is placed on mechanical ventilation, a NG/New Jersey tube should be placed in and initiated within 24 to 36 hours of admission. If the SIRS response is minimal and the patient can be managed on the hospital wards, then oral diet should be offered as tolerated and considered only when there is failure to advance the diet after 4 days. Early initiation and advancement of N should be performed with caution pending adequate resuscitation, as hemodynamically unstable patients requiring inotropic support may be at an increased risk of non-occlusive mesenteric ischemia. See Chapter 118. 22 Meta-analyses comparing N with PN in severe AP have shown a significant 2-fold reduction in the risk of total and pancreatic infectious complications, and a 2.5-fold reduction in the risk of death in patients receiving N.21,22 in an American Gastroenterological Association, AGA, technical review of 12 RCTs, and reduced the risk of infected peripancreatic necrosis, or 0.28. 95% CI 0.15 to 0.51, single organ failure, or 0.25, 95% CI 0.10 to 0.62, and MOF, or 0.41, 95% CI 0.27 to 0.63, 23 compared with PN. Stratifying patients with severe AP from those with mild to moderate disease helps triage patients needing admission to the ICU, adequate hydration, treatment for early organ failure, and provision of early N.24. Moreover, 3 RCTs comparing gastric with jejunal feeding in severe AP showed no significant difference in the levels of infusion between groups with regard to tolerance or clinical outcome. 25,26 Patients with chronic pancreatitis, CP, often have weight loss associated with hypermetabolism, and their nutrient intake can be further compromised by abdominal pain, malabsorption, and diabetes. 27,28 Jejunal feeding in such patients has been used to improve weight as well as to reduce abdominal pain, GI side effects, and narcotic use. 29 Oxidative stress has been implicated in the pathophysiology of CP, and antioxidant supplementation with selenium, ascorbic acid, beta-carotene, alpha-tocopherol, and methionine has been shown to provide pain relief in patients with CP. 30. In a randomized, placebo-controlled trial of antioxidants used to treat the pain of CP, although therapy significantly raised blood levels of antioxidants, it did not have any beneficial effect on pain or quality of life of the 92 patients studied. 31 These findings refute another RCT of 127 patients with CAMP who were treated with antioxidant supplementation that found 32% of patients became pain-free in the antioxidant group compared with 13% in the placebo group. 30 There was also a reduction in the number of painful days per month as well as the number of analgesic tablets used per month. 30 It should be noted that in this study, the mean patient age was 30 years and only slightly over a quarter had alcohol as the etiology for CP. Taken altogether, it would seem that elderly patients with alcohol as the etiology for their CP are less likely to benefit from antioxidant therapy than younger patients with a non-alcoholic etiology. Patients with CP should consume small, frequent meals and avoid foods that are difficult to digest, e.g., legumes. Fat restriction is no longer recommended. In patients with weight loss, medium-chain triglycerides, MCTs, may be useful to provide extra calories without causing steatorrhea. MCTs, however, may be poorly tolerated because they are foul-tasting and can cause cramps, nausea, and diarrhea. 27 32 Fat-soluble vitamins, vitamin B1-2, and calcium should be replaced as clinically indicated. 76 Part 2 Nutrition in Gastroenterology. Crohn disease, see Chapter 115, may be associated with malnutrition secondary to anorexia, malabsorption, increased intestinal losses, and the catabolic effects of systemic inflammation. 33 Deficiencies of magnesium, selenium, potassium, zinc, iron, and vitamin B1-2 are common. 34 Vitamin D deficiency is seen in about 50% of patients with CD. Besides a role in osteoporosis, vitamin D has also been implicated in the pathogenesis of CD, as it may downregulate TNF-alpha-related genes. 35-38 Although dietary therapy in IBD, with such commercial diets as the colitis 5-step, Atkins, South Beach, specific carbohydrate elimination, or the Maker's diet, has been proposed to help reduce symptoms, few well-designed placebo-controlled studies exist. The use of N, however, is an important component of IBD therapy for patients who cannot eat. RCTs in Asia comparing whole-day or half-day use of oral enteral formulas versus ad-lib oral diets have shown significant improvement in IBD symptoms with N. 39 Although glucocorticoid therapy has been shown to be more effective than N for inducing clinical remission of CD in adults, 40 N in children is just as effective as glucocorticoids in inducing clinical remission. An enteral formula with transforming growth factor beta is marketed specifically for IBD, but there is no robust evidence to recommend its use at this time. 41 Among hospitalized patients with active CD, no significant differences in improvement have been shown in patients randomized to receive N or PN. 42,43 Use of PN to achieve remission is problematic, as symptoms invariably recur once PN is stopped and an oral diet is resumed. The use of PN in IBD should be restricted to patients who have not responded to medications or in whom N cannot be delivered. Bowel rest is not necessary to achieve remission in CD. Malnutrition is an independent risk factor for postoperative complications. The ASPEN 2017 guidelines suggest that CD patients who require emergency surgery should receive additional nutrition in the form of N or PN to optimize postoperative outcomes. There are a paucity of high-quality studies, however, that specifically address the issue of nutritional support to prevent postoperative complications in CD patients. One meta-analysis showed that CD patients who received preoperative N or PN were 74% less likely to have postoperative complications compared with standard of care without N or PN, 20.0% versus 61.3%, respectively. 44 A separate meta-analysis showed that in selected patients, preoperative PN resulted in improved nutritional status, fewer postoperative complications, and reduced disease severity. 45 Liver disease malnutrition is common in advanced liver disease patients, with a prevalence of 50% to 90% in those with cirrhosis, depending on the methods used for nutritional assessment. 46 Malnutrition leads to more complications, e.g., ascites, hepatorenal syndrome, and has been shown to be an independent predictor of survival. Among patients with cirrhosis and portal hypertension who are malnourished, the crude in-hospital mortality rate is 14.1%, compared with 7.5% in those who are not malnourished. 47,48 Nutritional deficiencies among patients with liver disease result from many different factors acting in combination: malabsorption, altered metabolism, decreased nutrient storage, increased nutrient requirements, and decreased dietary intake resulting from anorexia, altered taste, and dietary restrictions. The etiology of anorexia is multifactorial and includes mechanical compression of the stomach by ascites as well as alterations in inflammatory and appetite mediators, e.g., increases in TNF-alpha and leptin. 46 patients with cirrhosis have been found to have dysgeusia, which can result from magnesium deficiency. 49 Restriction of dietary sodium and protein to manage ascites and hepatic encephalopathy, respectively, can further lead to reduced food variety and poor oral intake. In addition, patients with alcoholic cirrhosis often substitute alcohol for nutrient-rich foods. Decreased bile salt production results in an intolerance to high-fat foods and the development of fat-soluble vitamin malabsorption, especially in patients with cholestatic liver disease. Nutrient absorption may be further compromised by hypoalbuminemia, which results in edema of the small intestine. Also, some patients with alcoholic cirrhosis have CP, with resultant maldigestion of protein and fats. Portosystemic shunting can cause nutrients to bypass the liver, preventing them from being metabolized. Gluconeogenesis and protein catabolism are upregulated, glycogenolysis is downregulated, and insulin resistance occurs, leading to a depletion of muscle mass and fat mass because of their use as energy sources. Patients with cirrhosis have increased protein needs, and limiting their protein intake to prevent hepatic encephalopathy will only further accelerate protein-calorie malnutrition. 46 It has been shown that diets with a normal protein intake are well tolerated and do not worsen hepatic encephalopathy. See Chapter 94. 50 Patients should be fed according to their protein needs, and portosystemic encephalopathy treated with medications if it develops. Despite the high prevalence of insulin resistance among cirrhotic patients, carbohydrate restriction is not recommended as a method to prevent the hypoglycemia associated with impaired glycogen synthesis and hepatic stores. The branched-chain amino acids, BCAAs, valine, leucine, and isoleucine are used preferentially as a protein source by patients in liver failure because they are metabolized by the muscle, kidney, adipose, and brain tissue. In contrast, the aromatic amino acids, AAAS, tyrosine, phenylalanine, and methionine are metabolized and deamined solely by the liver. Normal serum AA concentrations are altered in cirrhosis, with a rise in AAAS and a fall in BCAAs. We are not certain at this time whether AA concentrations are deranged in cirrhotics with or without portal hypertension, or in both. It is postulated that the rise in concentration of AAAS precipitates hepatic encephalopathy because they act as false neurotransmitters. In the past, BCAA supplementation has been shown to reduce hyperammonemia, because the metabolism of BCAAs by skeletal muscle supplies carbon skeletons for the formation of alpha-ketoglutarate, which combines with two ammonia molecules to become glutamine. 46,51 Newer guidelines suggest that use of a formulation enriched in BCAAs should not be expected to improve patient outcomes compared with standard whole protein formulations in critically ill patients with liver disease. Outpatient RCTs suggest that long-term nutrition supplementation with oral BCAA granules may be useful in slowing progression of hepatic disease and prolonging event-free survival. 52-54 Patients with hepatic encephalopathy already receiving antibiotics and lactulose derive no further improvement in outcome, mental status or coma grade, by adding BCAAs to their therapy. 52-54 Micronutrient deficiencies can occur in patients with cirrhosis. Water-soluble vitamin, vitamin B complex and C, deficiencies can occur in both alcohol-associated and non-alcohol-associated liver disease. Thiamine deficiency can lead to Wernicke encephalopathy and Korsakoff dementia, not only in alcoholics, but also in patients with HCV-related cirrhosis. As a result, thiamine supplementation is recommended in all patients with cirrhosis. 55 Decreased levels of folate and vitamin B6 have been reported in HCV infection, and it is noted that pegylated interferon and ribavirin therapy further decrease levels of thiamine, riboflavin, and vitamin B6. 46 Fat-soluble vitamin deficiencies occur more frequently with cholestatic than parenchymal liver disease. Vitamin A deficiency has been reported in cirrhosis and is considered a risk factor for cancer, including HCC. 55 Vitamin D levels are low in patients with liver disease and fall as liver disease progresses. 56-58 As a result of which there is a high prevalence of osteoporosis in both cholestatic and non-cholestatic liver diseases. Use of immunosuppressives, including glucocorticoids, as part of the treatment regimen. Chapter 6 Nutritional Management 77-6 For autoimmune hepatitis and following liver transplantation increases the risk for metabolic bone disease. Other risk factors for osteoporosis in patients with chronic liver disease include advanced age, low BMI, hypogonadism, estrogen deficiency, low calcium intake, excessive alcohol use, tobacco use, and physical inactivity. 59 Vitamin E deficiency has been reported in both cholestatic and alcohol-associated liver disease, and low levels may facilitate progression of fatty liver to steatohepatitis. Zinc deficiency is also associated with liver disease, especially alcohol-associated liver disease, and may lead to anorexia, altered taste and smell, immune dysfunction, altered protein metabolism. 60 Hepatic encephalopathy, and impaired glucose tolerance. Zinc supplementation improves glucose metabolism, but data for improvement in hepatic encephalopathy are conflicting. 55 Because copper and manganese are excreted into bile, these trace elements should be decreased or omitted from PN formulas in patients with cirrhosis or cholestatic liver disease. 60 N is preferred over PN in patients with cirrhosis who require nutritional support, because liver function can worsen, and patients with ascites may not be able to tolerate the large fluid volumes associated with PN. 55 Excess dextrose and glucose can lead to steatosis, and patients receiving long-term PN can develop cholestasis, fibrosis, and cirrhosis. 60 There is an increased risk for catheter sepsis secondary to immune dysfunction and increased intestinal permeability. 61,62 Compared with cirrhotic patients, those with chronic liver disease have better outcome with greater caloric intake. Lack of liver glycogen stores and reduced capacity for gluconeogenesis can lead to hypoglycemia and reductions in lean body mass during prolonged NPO periods. For these reasons, cirrhotic patients should not go more than 3 hours without eating, and a bedtime snack should be ingested. Patients with liver disease complicated by severe malnutrition have been shown to have more infections, longer ICU stays, and longer hospitalizations after liver transplantation, but there currently are no RCTs to show that preoperative nutritional support improves clinical outcomes of liver transplantation. 63,64 Early postoperative N has been shown to reduce the incidence of sepsis, and postoperative PN has been shown to reduce the length of ICU stay. 65,66 Two randomized studies using a symbiotic, prebiotic and probiotic regimen given enterally after liver transplantation have shown a reduction in bacterial infections. 67,68 Diverticular disease patients with diverticular disease, see Chapter 121, are often provided with incorrect nutritional information. Patients are told to avoid nuts or foods that contain seeds because of fear that the hard, small particles may lodge in a diverticulum and precipitate diverticulitis, despite evidence showing no harm. 69,70 A number of previous retrospective and epidemiologic studies have suggested benefit from fiber in preventing symptomatic diverticular disease, but no well-designed RCTs support this practice. 71 Fiber intake should be at least 25 g/day and provided as insoluble fiber, such as that contained in wheat bran muffins, and fiber-based cereals. The use of probiotics has had some success in treating and preventing diverticulitis. 72 The most frequently investigated probiotics studied to date have been different strains of lactobacilli. A systematic review of 11 studies on probiotics in the treatment of diverticular disease showed regression or reduction of symptoms in a majority of the 764 patients evaluated. 73 However, High-quality data on prevention of complications and recurrence are scant, and currently the AGA guidelines recommend against the use of probiotics after uncomplicated diverticulitis. 74 Obesity and physical inactivity have been shown to increase risk of symptomatic diverticular disease in both men and women. 75-77 Dumping syndrome, which occurs when food passes too rapidly into the small intestine, can occur after gastrectomy, vagotomy, or esophageal surgery, and is increasingly being seen with the growing popularity of bariatric surgery. See Chapter 8. Two types of dumping syndrome are recognized. Early dumping syndrome occurs within 30 minutes of a meal and is characterized by abdominal pain, diarrhea, borborygmi, bloating, nausea, and vasomotor symptoms including flushing, sweating, tachycardia, hypotension, and syncope. This syndrome results from shifting of fluids out of the intravascular space and into the hyperosmolar environment of the duodenal lumen, as well as from enhanced release of GI hormones caused by a high carbohydrate load entering the small intestine. These hormones, including enteroglucagon, pancreatic polypeptide, peptide YY, vasoactive intestinal polypeptide, and neurotensin, have been implicated in the etiology of the vasomotor symptoms by causing systemic and splanchnic vasodilation. 78,79 Late dumping syndrome occurs 1 to 3 hours after a meal and is characterized by hypoglycemia, sweating, hunger, fatigue, and syncope, and is thought to be related to hypoglycemia from the rapid, earlier, increase in insulin via GLP-1 in response to the excessive carbohydrate load in the jejunum. Dumping syndrome is diagnosed by clinical assessment and a modified oral glucose tolerance test. 78 Nutritional therapy for dumping syndrome is described later in this chapter. Cancer protein calorie malnutrition is a common problem for cancer patients. At presentation, the frequency of weight loss associated with cancer varies based on tumor type, 31% to 40% in patients with sarcomas, breast and hematologic cancers, 54% to 64% in patients with colon, prostate, and lung cancers, and over 80% in patients with pancreatic and gastric cancers. 80 Malnutrition is not only affected by the type of cancer, but also by the specific anti-tumor therapy regimen and patient characteristics, age, gender, and comorbidities such as diabetes and GI disorders. 81 Malnutrition has been associated with reduced effectiveness of anti-cancer therapies, leading to longer duration of treatment and hospital stays, increased cost, and increased morbidity and mortality. The etiology of malnutrition in cancer patients is multifactorial and includes cancer cachexia, which is caused by tumor-induced metabolic abnormalities, impaired caloric intake, maldigestion, malabsorption, and GI toxicity from the cancer therapies themselves. Important mediators of cancer cachexia are thought to include proteolysis-inducing factor and lipid-mobilizing factor, which are produced by tumors, as well as alterations in the balance of neurohormones like neuropeptide Y, appetite-stimulating, and pro-opiomelanocortin, anorexigenic stimulating. Proteolysis-inducing factor leads to decreased protein synthesis, increased protein degradation, and an increase in pro-inflammatory cytokines, interleukin-6 and interleukin-8. Lipid-mobilizing factor has been shown to increase lipolysis, leading to decreased body fat and weight, independent of caloric intake. 82 Most practitioners start a dietary regimen for cancer patients by modifying the amount of food and pattern of eating, i.e., small, frequent meals, using additional foods or supplements, or changing the formulation of the food, liquids, pureed foods, etc. Appetite stimulation with glucocorticoids and megestrol acetate has been used successfully in cancer patients with mild malnutrition. 83 Although both agents lead to improved appetite and weight gain, use of megestrol acetate is associated with a higher risk of DVT. 84,85 Routine use of nutritional support in non-malnourished cancer patients who are undergoing chemotherapy, radiation, or surgery is not recommended unless they are unable to ingest or to absorb adequate nutrients for a prolonged period of time, in which case studies have shown an improvement. 78 Part 2 Nutrition in gastroenterology in weight and nitrogen balance, but not survival. 86 and has been used successfully in patients with head and neck cancer to prevent weight loss, reduce hospitalizations, and reduce interruptions in chemotherapy and radiotherapy, although dependence on PEG feedings may delay return of swallowing function and PO intake. Routine use of PN during chemotherapy has not been shown to decrease toxicity, improve tumor response, or decrease mortality. 86 PN has been found beneficial in patients who have developed severe GI mucositis after bone marrow or hematopoietic stem cell transplantation. 87 in hematopoietic stem cell transplant patients, and compared with PN is associated with increased morbidity, diarrhea, and hyperglycemia and delayed time to engraftment but less weight and body fat loss. 86 Use of PN support in the cancer patient should be restricted to those patients with a reasonable life expectancy and a sufficient quality of life, Karnofsky score greater than 50, who are not expected to maintain their nutritional needs for a prolonged period. See Chapter 132. Obesity. Obesity is the second leading cause of preventable death, due to its association with type 2 diabetes, hypertension, coronary artery disease, cerebrovascular disease, obstructive sleep apnea, cancer, osteoarthritis, and depression. 88 Despite abundant adipose tissue, obese critically ill patients should receive early and timely nutrition therapy. Nutritional assessment of critically ill obese patients can be difficult. Current equations to estimate energy expenditure are invalid in this population, so indirect calorimetry remains the gold standard. See Chapter 5. In an obese patient with glucose intolerance or diabetes, the concentrated glucose solution in PN can lead to hyperglycemia, which in critically ill patients has been shown to increase the risk for nosocomial infection, weaken the immune response, delay wound healing, and increase overall mortality. During metabolic stress, protein breakdown leads to gluconeogenesis. Several studies have suggested that protein-rich hypocaloric feeding, 2 grams protein/kg ideal body weight IBW/day and 65% to 70% of caloric requirements, also known as permissive underfeeding, is advantageous over standard nutritional regimens because oxidation of endogenous lipid stores supplies the energy source while protein supplementation is used to promote protein anabolism. This approach, however, is still debated. With permissive underfeeding, hyperglycemia is seen less often, and weight loss may occur with maintenance of lean body mass. 88 In critically ill obese patients, the American Society for Parenteral and Enteral Nutrition recommends 11 to 14 kcal/kg actual body weight per day for BMI 30 to 50 and 22 to 25 kcal/kg IBW/day for BMI greater than 50. The recommended dose of protein is 2 g/kg IBW for BMI of 30 to 40, and 2.5 g/kg IBW for BMI greater than or equal to 40.61. The United States Preventive Service Task Force recommends that all adults be screened for obesity, and those with a BMI of 30 kg/m2 or higher be offered a referral to intensive multi-component behavioral interventions. Bariatric surgery is recommended for individuals with a BMI greater than 40 kg/m2 and for those with a BMI greater than 35 kg/m2 who have obesity-related comorbidities. See Chapter 8. Micronutrient deficiencies, particularly iron and vitamin D, are commonly present in obese patients and should be corrected preoperatively. After bariatric surgery, patients are sequentially advanced from a clear liquid diet to a solid diet, and postoperative nutritional guidance by a dedicated bariatric dietitian is highly encouraged. In patients with Roux-en-Y gastric bypass, limitation in oral intake is necessary because of the small size of the gastric pouch. The shorter the length of the common channel in the Roux-en-Y gastric bypass, the more likely there will be micronutrient and macronutrient deficiencies. 89 The laparoscopic adjustable gastric band, which is least likely to cause nutritional problems, is gradually being phased out because of its high rate of complications requiring removal in greater than 40% of cases. The vertical sleeve gastrectomy is being increasingly utilized because of its less disruptive effect on GI physiology and its effective impact on weight reduction and decreased risk of diabetes. Not only is understanding a patient's post-surgical anatomy important, but also a basic knowledge of the various sites of nutrient absorption is essential to prevent and diagnose nutrient deficiencies. Table 6.1. Post-bariatric surgery nutritional deficiencies can be divided into three types: protein-calorie malnutrition, vitamin and mineral deficiencies, and dehydration. Lifelong vitamin supplementation is started shortly after hospital discharge to prevent development of nutritional deficiencies, which can develop gradually and may take years to manifest. 88 Deterioration of nutritional status can occur post-operatively for a variety of reasons, including gastrojejunal anastomotic strictures and an excessively long segment of bypassed biliopancreatic limb. Micronutrient deficiencies can lead to anemia, iron, copper, zinc, folate, vitamins B1, A, E, metabolic bone disease, calcium, vitamin D, encephalopathy, thiamine, polyneuropathy and myopathy, thiamine, copper, vitamins B1, and E, visual disturbance, thiamine, vitamins A and E, and rash, zinc, essential fatty acids, vitamin A, see Chapter 103. 89 Iron, folate, calcium, and vitamin B1 deficiencies can occur after Roux-en-Y gastric bypass. After biliopancreatic diversion, zinc, sodium, chloride, magnesium, and fat-soluble vitamin deficiencies can occur. Dehydration is common after bariatric surgery, especially in warm weather and after vigorous exercise. The patient's ability to drink large amounts of fluid is restricted because of the reduced size of the stomach. Approximately 2 L of fluid intake is usually recommended per day, though the amount can vary depending on the specific patient and his or her daily activity. 88 For those not meeting criteria to undergo bariatric surgery, pharmacotherapy is an option. According to the 2013 Joint Guidelines from the American College of Cardiology, the American Heart Association, and the Obesity Society for the Management of Overweight and Obesity in Adults, and the Endocrine Society's Clinical Practice Guidelines on the Pharmacologic Management of Obesity, pharmacotherapy for obesity should be considered if patients have a BMI of greater than or equal to 30 kg/m2 or a BMI of greater than or equal to 27 kg/m2 with weight-related comorbidities, such as hypertension, dyslipidemia, type 2 diabetes, or obstructive sleep apnea. 90,91 There are 6 main anti-obesity medications: phentermine, phentermine/topiramate, orlistat, lorcaserin, bupropion/naltrexone, and liraglutide, see Chapter 7. Phentermine is the most commonly prescribed medication for obesity in the USA. It is a Schedule IV controlled substance and classified as an adrenergic agonist that functions to increase resting energy expenditure and suppress appetite. As monotherapy, it is indicated for short-term use, 3 months, as there are Table 6.1 sites of nutrient absorption in the stomach and small intestine site nutrient: stomach water, ethyl alcohol, copper, iodide, fluoride, molybdenum, duodenum, calcium, iron, phosphorus, magnesium, copper, selenium, thiamine, riboflavin, niacin, biotin, folate, vitamins A, D, E, K, jejunum dipeptides, tripeptides, amino acids, calcium, phosphorus, magnesium, iron, zinc, chromium, manganese, molybdenum. Thiamine, riboflavin, niacin, pantothenic acid, biotin, folate, vitamins B6, C, A, D, E, K, ilium folate, magnesium, vitamins B1, C, D. Data from Ka Faraniham, Shakora S.A. Nutritional support of the obese and critically ill obese patient. SURG Clin North M 2011, 91:83755, 89, RET with permission. Chapter 6 Nutritional Management 79.6 No long-term safety trials. When combined with topiramate ER, phentermine may be used long-term. Orlistat promotes weight loss via inhibition of pancreatic and gastric lipases, thus preventing the absorption of fat. Orlistat also has the added benefit of lowering serum glucose and improving insulin sensitivity. 92 Lorcaserin is a selective serotonin 2C receptor agonist for long-term treatment of obesity. The 5-hydroxytryptamine 2C receptor has a role in the regulation of the dopamine system, and is postulated to affect food-related behaviors. Two agents, bupropion, a dopamine and norepinephrine reuptake inhibitor, and naltrexone, an opioid antagonist, were FDA approved separately for the treatment of opioid dependence and alcohol use disorder. Together, naltrexone/bupropion affects the arcuate nucleus of the hypothalamus and the mesolimbic dopamine reward circuit, acting to regulate appetite and food cravings. Liraglutide was approved by the FDA for chronic weight management and treatment of type 2 diabetes. It mimics GLP-1, which is released in response to food intake, and acts to reduce hunger, decrease food intake, and delay gastric emptying. 93 Critical illness determination of nutritional risk in critically ill patients is important, as it emphasizes the fact that risk from a nutritional standpoint is twofold, driven both by deteriorating nutritional status and disease severity. While patients with higher nutritional risk tend to have greater degrees of GI intolerance resulting in more difficulty in complying with the prescribed N regimen, they are more likely to show improved outcomes from nutritional interventions than those with lower nutritional risk. American Society for Parenteral and Enteral Nutrition guidelines for nutritional therapy in the critically ill adult patient recommend that all patients admitted to the ICU undergo an initial nutritional risk screening. While the concept of nutritional risk is very important, use of the tools to determine such risk, the Nutritional Risk Screening 2002 or NRS 2002 and the Nutrition Risk in the Critically Ill or Nutrix score, is problematic. Patients determined to be at high nutritional risk, NRS 2002 greater than 5 or Nutrix score greater than or equal to 5, should have N started early within 24 to 36 hours of admission to the ICU. Advancement to goal should take 3 to 4 days in order to minimize the chance for overfeeding, as exogenous feeds are additive to endogenous gluconeogenesis by the liver, GI intolerance is monitored, electrolytes are scrutinized for evidence of refeeding. Hypophosphatemia, hypotensive patients on vasopressive agents are stabilized, and the process of autophagy is supported. 94 Getting to the protein goal sooner, up to 2.0 g/kg/day, is more important than getting to the caloric goal, 20 to 25 kcal/kg/day. Efforts to provide a goal of approximately 80% of estimated or calculated goal energy requirements should be made in order to achieve the clinical benefit of N over the first week of hospitalization while avoiding risk of overfeeding. Although trophic feeds provide the non-nutritional benefit of feeding by preventing mucosal atrophy and maintaining intestinal integrity in low to moderate risk patients, they are insufficient to achieve the usual endpoints sought for N therapy in high-risk patients. More than 50% to 60% of goal energy is required to prevent increases in intestinal permeability and systemic infection in burn and bone marrow transplant patients. 95 To promote faster return of cognitive function in head injury patients. 96 And to reduce mortality in high-risk hospitalized patients. 97 Likewise, a prospective study of high-risk surgery patients, NRS 2002 greater than or equal to 5, who received sufficient preoperative nutrition therapy, greater than 10 kcal/kg/day for 7 days, had significant reductions in nosocomial infections and overall complications compared with patients who received insufficient therapy. 98 Once N has commenced, patients should be monitored daily for tolerance. Inappropriate interruption of N should be avoided, with NPO orders surrounding the time of tests and procedures kept to a minimum to avoid propagation of ileus and prevention of inadequate nutrient delivery. Gastric residual volumes, GRVs, should not be used as part of routine care to monitor ICU patients on N, as GRVs do not correlate with the incidence of pneumonia, regurgitation, or aspiration, and are a poor surrogate marker for gastric emptying. N protocols should be designed and implemented to increase the overall percentage of goal calories provided, with consideration for a volume-based feeding protocol to clearly define the daily goal volume of N to be infused. Appropriate adjustments to protocol should be made in the setting of hemodynamic compromise or instability. In this scenario, N should be withheld if vasopressive therapy is being initiated. Initiation or reinitiation of N may be considered with caution once the patient is fully resuscitated and stable for 24 to 36 hours and pressor support has begun to be withdrawn. Critically ill patients are at increased risk for subclinical ischemia/reperfusion injury to the intestine, but data show that ischemic bowel is a very rare complication of N, and that patients on stable low doses of vasopressors or even multiple vasopressors had lower ICU and hospital mortalities when N was used than when it was withheld. 99 In patients at low nutritional risk, PN should not be used until after the first 7 days following ICU admission if the patient cannot maintain volitional intake and early N is not feasible. 61 If N is not feasible in patients at high nutritional risk, it is appropriate to initiate PN as soon as possible after hospital admission, once resuscitation has been performed. 61, 100 In any critically ill patient, regardless of risk, who is already on N-tube feeding but receiving less than 60% of the prescribed goal regimen, addition of supplemental PN should be withheld until after 7 to 10 days from admission. As tolerance to N improves, the amount of PN energy should be reduced and finally discontinued when the patient is receiving more than 60% of target energy requirements from N. In all ICU patients who require PN, high-protein hypocaloric PN should be considered initially over the first week, with provision of 80% of energy requirements, 20 kcal/kg actual body weight/day. Compared with eucaloric PN, permissive underfeeding has been shown to reduce the incidence of hyperglycemia, infections, ICU, and hospital lengths of stay, and duration of mechanical ventilation. 61, 101, 102 A combination of antioxidant vitamins, including vitamins E and C, and trace minerals, including selenium, zinc, and copper, should be given enterally or parenterally to all critically ill patients receiving nutrition support, as these may reduce mortality for patients with burns, trauma, and critical illness requiring mechanical ventilation. 61, 100 Nutritional therapy enteral nutrition and supports both the structural and functional integrity of the GI tract, and sustains structural integrity by maintaining mucosal mass and villus height, stimulating epithelial cell proliferation, promoting the production of brush border enzymes, and maintaining the secretory immunoglobulin, IgA producing immunocytes, which make up the gut-associated lymphoid tissue, GALT. And also maintains the functional integrity of the GI tract by maintaining tight junctions between the intraepithelial cells, sustaining a thick mucus layer, stimulating blood flow, and inducing the production and release of various trophic endogenous agents, including gastrin, CCK, bomazine, and bile salts. The provision of N supports the role of the commensal microbiome and helps prevent the emergence of a virulent pathobiome in response to critical illness. 103 In those patients who will not or cannot eat because of some dysfunction of the GI tract, a feeding tube is necessary to provide 80 Part 2 nutrition in gastroenterology feedings. The radiologist, gastroenterologist, or surgeon usually places these enteral access devices. This can be done at the bedside, fluoroscopically, endoscopically, or in the operating room, depending on the specific device and the expertise available. 104 Nasoenteric tube access. The use of small bowel feedings to prevent tube feeding aspiration events is a complicated and contentious issue. Small bowel feeding is recommended for critically ill patients determined to be at high risk of aspiration or those shown to be intolerant to gastric feeding. 61, 105 Bedside nasoenteric tube, NET, placement, Fig. 6.1, is the most common enteral access technique used in the hospital and long-term care environments. Use of a commercial tube with an electromagnetic GPS imaging system greatly facilitates post-caloric placement of a net. Alternatively, the endoscopic over-the-guide-wire net, ENET, technique can be used when placement under direct visualization is desired, Fig. 6.2. A bridle can be used to secure the ENET once it is placed, Fig. 6.3. For bedside net placement, typically, an 8 to 12 FRNG tube is lubricated and passed into the stomach with the patient's head flexed. The patient ingests sips of water to assist in passage of the tube. 106 Bedside auscultation to confirm proper position of the NG tube is problematic, and with the exception of those patients in whom tube placement was achieved using the electromagnetic GPS imaging system, every patient should have a bedside plain film to confirm proper positioning of the NG or New Jersey tube before initiating feedings. Patient's mental status does not change this recommendation. Surprisingly, the success rate for spontaneous small bowel placement is greater for unweighted than weighted feeding tubes when placement is at the bedside, 92% versus 56%, and, in fact, the weighted tip may actually be an impediment to the tube's spontaneous passage. 107 New Jersey feeding tubes can be placed endoscopically at the bedside with the patient moderately sedated. In the drag and pull method, a suture is attached to the end of a New Jersey tube and used to drag the tube into position in the small intestine with a grasping forceps. Because it is often difficult to release the suture from the grasping forceps, and also to remove the endoscope without removing the adjacent New Jersey tube, a hemoclip can be used to drag the tube and then clip it to the small intestine. A second common technique, the over-the-guide wire technique, requires the use of a 5 mm neonatal gastroscope passed through the nares to place a guide wire into the small intestine. The endoscope is removed, and the guide wire is left in place. A feeding tube is then passed over the guide wire and into position in the small intestine, with a success rate of 90% to 100%. 108-110 A similar version of this technique uses a pediatric colonoscope passed through the mouth down into the small bowel. A guide wire is passed out into the bowel lumen, the scope is withdrawn, and the wire transferred out through the nose before final placement of the tube over the wire. 111-112 Nasoenteric tubes should be used in patients who will require N via NG or New Jersey access for less than 1 month. Patients who have experienced repeated early failure to keep nets in place or those anticipated to require longer duration of feeding beyond 1 month should receive more durable enteral access, such as a PEG, direct percutaneous endoscopic jejunostomy, DPEJ, a combination percutaneous endoscopic gastrojejunostomy, PEGJ, surgical gastrostomy or surgical jejunostomy. Percutaneous endoscopic enteral access insertion of a percutaneous enteral access tube usually requires the use of moderate or deep sedation and can be performed in the endoscopy suite, in the operating room, or at the bedside. Tube drag wire untethered endoscopy New Jersey PEGJ Fig 6.1 Prioritizing techniques for enteral access. Dragging a tube into place increases the chance for proximal displacement when the scope is withdrawn. Dragging a wire is better, but torsion on the wire still impedes endoscopy. Untethered endoscopy technique allows placement of a wire and then delivery of the tube over the wire directly into the small intestine without the need to drag either into place using the endoscope. New Jersey, nasojejunal, PEGJ, percutaneous endoscopic gastrojejunostomy. Reprinted with permission from Chandra C. Kara V. Kochman M. Techniques in Gastrointestinal Endoscopy, Elsevier. Chapter 6 Nutritional Management 81-6 Lud A Lud B D E F C G H Fixed wire into final position. Reprinted with permission from Chandra C. Kara V. Kochman M. Techniques in Gastrointestinal Endoscopy, Elsevier. Alternative technique for the final wire transfer, an assistant pins the wire to a point in space, using a bedside table, and the tube is then slid over the nares at the exact same rate that the wire is withdrawn out from the distal end of the feeding tube, again to avoid displacing the wire tip. H. In and is felt against the finger in the posterior pharynx. G. In one technique for the final wire transfer, the feeding tube is passed over the wire down through the posterior pharyngeal wall while traction is placed on the wire protruding out through the nose, pulling on the wire until the wire is straight and tension through the mouth. The tip of the wire is then passed through the oronasal transfer tube. E and F, the index finger is then used to pin the wire against cm. By quickly pushing the endoscope back in 2 to 3 cm, the bowel comes off the endoscope 1 to 2 folds at a time. D, with the wire protruding out is used for withdrawing the endoscope off the guide wire. With the bowel pleated on the end of the endoscope is withdrawn 5 to 6 is passed down through the operating channel, to prevent displacement of the wire tip from its position in the small intestine. C. The keyhole technique wire extended out beyond the end of the scope. B. in the initial wire transfer, the scope is withdrawn out from the mouth at the same rate the guide wire Fig 6.2 over the guide wire endoscopic nasoenteric tube technique. A pediatric colonoscope is passed down below the ligament of Treitz and the 82 Part 2 Nutrition in Gastroenterology in comparison to nasoenteric access. Percutaneous enteral access has been shown to be more reliable, allowing patients to receive more calories daily because of a reduction in tube dysfunction. 113 Indications for percutaneous access devices. Percutaneous access devices, such as a PEG, are indicated for patients who will be unable to maintain sufficient nutritional intake for more than 1 month, despite a functional GI tract. While certain patient populations such as those patients with a stroke may see tremendous benefit from PEG placement as a bridge to return of swallowing function and oral intake, in other populations such as patients with advanced dementia or end-stage malignancy, benefit is more limited. 114-119 In high-risk patients, a high mortality after PEG is usually not a result of the procedure itself, but a reflection of the patient's comorbidities and moribund status. In addition to providing access for nutrition, PEG tubes may be placed for hydration and administration of medications as well as for gastric decompression. Some of the more common medical indications for PEG placement are described below. Cancer. Patients with head and neck cancer, HNC, are at high risk for malnutrition stemming from dysphagia from the tumor itself or from required anti-tumor therapies. Approximately 50% of patients with HNC require alternative means of nutritional support. 120 And support via PEG has been shown to reduce the number of hospitalizations required from dehydration and malnutrition, prevent weight loss, and avoid treatment interruptions. 121 Tumor implantation at the ostomy site from dragging the PEG tube past the exophytic tumor mass is rare. In a retrospective case series of 304 patients receiving PEG tubes for HNC, only 2 developed stomal site metastases, 0.92%. 122 PEG placement in HNC is controversial only in that return of swallowing function and resumption of oral intake may be delayed by dependence on the PEG feedings. In patients with malignant bowel obstruction, a PEG tube can also be safely and effectively used for intestinal decompression. Such a venting PEG obviates the need for an NG tube, relieves symptoms of nausea and vomiting, and can allow end-of-life patients to be discharged from the hospital tolerating some degree of an oral soft diet. 123 Use of N or PN in advanced unresectable cancer is controversial. The Karnofsky Performance Scale Index can be used to assess quality of life in individual patients, see Chapter 132. Use of N or PN may provide improved energy and psychological benefit in cases of advanced unresectable malignancies and should be considered if the patient has a Karnofsky score greater than 50 or if the initiation of either route of nutritional therapy allows the treatment regimen to be completed. 124 Ultimately, treatment strategies should reflect the preferences and values of the patient, as patient autonomy is paramount. The final decision to place a PEG may be based on cultural, personal, family, spiritual, and religious beliefs, and may not always be supported by scientific facts. Stroke. Data support the use of PEG tubes in patients with stroke-related dysphagia, as a bridge to return of swallowing function and oral intake. Compared with NG feeding, early PEG placement was found to be associated with a lower incidence of ventilator-associated pneumonia. 125 In a Cochrane meta-analysis, PEG feeding compared with NG tube feeding was associated with a reduction in treatment failures, and a higher overall rate of delivery of feeds. Dementia. Despite widespread use, the benefit gained from PEG placement in patients with dementia remains unclear. In a prospective cohort study of more than 36,000 nursing home residents with recent onset of dysphagia, neither insertion of a PEG tube nor the timing of that insertion affected survival. 126 The most common reasons for PEG placement in patients with dementia include reduction in risk of aspiration, maintenance of skin integrity with prevention of pressure sores, improvement in quality of life, and prolongation of survival. The likelihood that these benefits will be achieved by PEG placement is limited. When patients with dementia are changed from hand feeding by staff or family members to PEG tube feeding, they are deprived of taste, touch, nurturing, and social interaction. 127 Over 70% of patients with dementia who have feeding tubes need to be restrained. 116 Risk of developing pressure ulcers in nursing home residents with PEG tube placement may actually increase because of decreased mobility and the need to be restrained. 119 In a prospective study of 150 patients followed after PEG tube placement, 70% showed no improvement in functional status or overall subjective health status. 128 While the patient's quality of life and health status may not directly improve, his/her care becomes more manageable. Family and caregivers often experience less frustration and a greater sense of accomplishment following PEG placement. 128 PEG tube placement may do little to reduce aspiration pneumonia, as patients are still capable of aspirating oropharyngeal secretions. 129 Multiple professional medical organizations, including the Society for Post-Acute and Long-Term Care Medicine, the American Academy of Hospice and Palliative Medicine, and the American Geriatrics Society, all recommend against the insertion of percutaneous feeding tubes, and support oral-assisted feedings as the preferred method. 124B3134526A Fig 6.3 Bridle technique for securing endoscopic nasoenteric tube. A. Using two 5FR neonatal feeding tubes, or B. A commercial devising using two flexible sticks with magnetic ends. Reprinted with permission from Chandra C. Kara V. Kochman M. Techniques in Gastrointestinal Endoscopy, Elsevier. Chapter 6 Nutritional Management 83-6 Percutaneous endoscopic gastrostomy PEG was developed by Ponsky and Goddard in the early 1980s. 130 The procedure involves placement of a PEG tube after endoscopic transillumination of the abdominal wall to choose an appropriate gastrostomy site, Fig 6.4. If there is no transillumination or discrete indentation of a probing finger seen, the procedure should not be performed. The use of prophylactic 4 antibiotics before the procedure is important to prevent peristomal infections after the procedure. 131,132 An antibiotic with optimal skin coverage, such as 4-cefazolin, 1 gram, should be administered 30 minutes prior to the procedure. Placement of a PEG tube can be accomplished by either the Ponsky, pull, or Sachs-Vine, push, technique, depending on physician preference, as both are equally effective. 133 A third technique, Russell introducer, may be indicated in cases of an exophytic oropharyngeal or esophageal cancer, recent oropharyngeal incisions from a head and neck surgical procedure, or a tight esophageal stricture that impedes passage of the scope or PEG tube. 134 With the Russell technique, T-fasteners are placed percutaneously to attach the wall of the stomach to the anterior abdominal wall. An incision is made in the abdominal wall, and a fistulous tract is created into the stomach and sequentially dilated. Ultimately, a PEG tube with a balloon internal bolster, similar in design to balloon replacement tubes, is passed through the newly created insertion site. 135 Relative contraindications for PEG placement include the presence of gastric varices, major gastric resection, ascites, and coagulopathy. The most common PEG tubes for adult patients range in size from 16 to 20 fr, and are made of silicone. 136 A larger diameter PEG tube is associated with a greater likelihood of side torsion and enlargement of the stomal tract diameter. The gastrostomy site should be cleansed with mild soap and water, rather than hydrogen peroxide, which can irritate the skin and lead to stomal leakage. To absorb any moisture and to avoid excess tension, a single layer of gauze should be placed under the external bumper. Because of the risk of peristomal skin maceration and breakdown, occlusive dressings should not be used. Replacement PEG tubes are broadly divided into two categories: replacement gastrostomy tubes and low-profile devices. Replacement gastrostomy tubes usually have a balloon-type internal bolster, Fig 6.5. These balloon tubes can be inserted blindly through the gastrostomy site into the gastric lumen. The balloon is inflated to serve as the internal bolster. Because of balloon breakage, the tube often requires replacement within 3 to 6 months. There also are replacement PEG tubes with a distal internal bumper. The internal bumper is stretched with a stylet and pushed blindly through the gastrostomy site. The stylet is then removed, allowing the internal bolster to assume its previous shape. Low-profile gastrostomy devices, Fig 6.6, provide skin-level access to the gastric lumen and may be particularly useful for disoriented patients who may habitually tug at their bedclothes and pull out their tube connections. The internal bolster of these low-profile devices may be an inflatable balloon or a disposable internal bolster that requires a stylet for placement. Low-profile PEG tubes come in predetermined stem lengths, and the gastrostomy tract length must be measured to choose the correct device. XXXXXXOOOABC Fig 6.4 Steps to localize percutaneous endoscopic gastrostomy PEG, percutaneous endoscopic gastrojejunostomy, PEGJ, and direct percutaneous endoscopic jejunostomy, DPEJ, sites. A. The traditional PEG site is marked by the X in the left upper quadrant. Better placement is above the umbilicus, close to the midline, or slightly to the patient's right of the midline position, circles. The PEG then is in the gastric antrum, which is ideal should conversion to a PEGJ be required later. X with circles show the tremendous variability in the site for DPEJ placement, which can occur anywhere from the left costal margin down to the left iliac crest. B. CT scan shows that the PEG site slightly above or to the patient's right of the umbilicus coincides with the area with the most direct, perpendicular, and shortest tract in the gastric antrum. Traditional sites in the LUQ have a longer, more tangential tract into the midbody or even lower fundus. C. Placing a coin in the umbilicus, dark circle, and injecting 500 ml of air through the NG tube before PEG placement helps identify the gastric antrum, easing selection of the PEG site. Reprinted with permission from Chandrasekhara V. Kochman M. Techniques in Gastrointestinal Endoscopy, Elsevier. Fig 6.5 Replacement gastrostomy tube. 84 Part 2 Nutrition in Gastroenterology. To access the low-profile device for feeding or gastric decompression, a separate access tube must be used to engage a valve in the top of the device. Percutaneous endoscopic gastrojejunostomy for patients for whom small bowel feedings are desired. Endoscopic percutaneous access to the small intestine may be obtained by one of two ways. The first way involves a PEGJ, where a PEG is placed in the standard fashion, after which various techniques may be used to place a jejunal feeding tube through the PEG into the small intestine. 108,137,138 The second way involves a direct PEG, DPEJ, where a small diameter gastrostomy tube is placed directly into the proximal jejunum, using a variation of the Ponsky pull technique. Three common techniques are used for PEGJ placement. With the Kirby technique, Fig 6.7, a guide wire passed through the PEG is grabbed by an extra-long 320 cm biopsy forceps and dragged down into the proximal jejunum. The scope is withdrawn back to the proximal stomach above the PEG site, holding the wire in place with the forceps. A 9 or 12 FRJ tube is then passed through the existing PEG over the guide wire and into position in the small intestine, Fig 6.8 and 6.9. The average longevity of this tube system is about 120 days. 137 With the Jolin technique, Fig 6.10. A wire polypectomy snare is inserted through the gastrostomy tube into the stomach, and the endoscope is then passed through the open snare and advanced as far as possible down into the proximal jejunum. A standard 0.035 inflexible tip guide wire is passed through the endoscopic channel and passed out further into the small bowel. The endoscope is then slowly withdrawn back to the proximal stomach. The guide wire is withdrawn out through the gastrostomy tube, forming a wire loop. Pulling on the end of the wire exiting the endoscope helps determine the proximal end of the wire loop, which can then be brought out. Fig 6.6 Low-profile percutaneous endoscopic gastrostomy device. AB Fig 6.7 Over the guide wire percutaneous endoscopic gastrojejunostomy technique, also known as the Kirby technique. A single-stranded guide wire passed through a valve seated in the PEG is grasped by a biopsy forceps passed down through a pediatric endoscope. The biopsy forceps is pushed outward through the end of the scope, holding the wire in place below the ligament of Treitz. B. The endoscope is then withdrawn back into the stomach as the biopsy forceps is pushed outward through the end of the scope, holding the wire in place below the ligament of Treitz. Once the scope has been withdrawn back into the proximal stomach, the jejunal extension tube is passed over the wire until the distal end strikes the biopsy forceps at the end of the wire. Reprinted with permission from Chandrasekhara V. Kochman M. Techniques in Gastrointestinal Endoscopy, Elsevier. Fig 6.8 Gastrojejunostomy, or Percutaneous Endoscopic Gastrojejunostomy, Feeding Tube. A suture at the end of the jejunal feeding tube aids in its placement and can be secured to the jejunal wall using a hemoclip. Fig 6.9 Percutaneous Endoscopic Gastrojejunostomy showing over the guide wire placement technique. 6 DCA air plug seated B. Chandrasekhara V. Kochman M. Techniques in Gastrointestinal Endoscopy, Elsevier. Into final position, with the tip located well below the ligament of Treitz. Reprinted with permission from Chan as the operator passes the jejunal tube down through the peg. E. The jejunal extension tube is passed down is then pulled out through the peg. D. An assistant provides a point in space to secure or fix the guide wire channel of the scope, to indicate which side of the wire loop represents the proximal end of the wire. The loop holds the wire loop coming out from the peg, the operator pulls on the wire extruding from the operating stomach. C. The snare is then closed on the wire, which is pulled out through the peg, while the assistant in place below the ligament of Treitz. The air plug may be seated to allow observation of the snare within the wire transfer technique. The endoscope is withdrawn back to the proximal stomach, keeping the tip of the wire below the ligament of Treitz, after which the wire is extended beyond the end of the scope. B. Using careful a pediatric colonoscope is passed into the stomach, through the snare, and then down into the small intestine and then a snare placed through a homemade or commercial air valve, Fig 6.13, is passed into the stomach. Lin technique. A. After initial placement of the peg tube is cut down short to approximately 10 cm, Fig 6.10 through the snare percutaneous endoscopic gastrojejunostomy technique, also known as the JO 86 Part 2 Nutrition in Gastroenterology through the peg. The J-tube is threaded over the wire until its proximal end is seated in the gastrostomy tube, and the guide wire is then removed. A one-piece PEG-J system is available and generally used as a replacement device passed through a mature stomal tract. This tube can be passed over a guide wire during endoscopy using a variation of the Kirby technique. The internal bolster on this system is a balloon. Direct percutaneous jejunostomy DPEJ involves the direct placement of a small diameter 14 to 16 fr peg tube into the small intestine using a modified Ponsky pull technique and a pediatric colonoscope to reach a puncture position beyond the ligament of Treitz, Fig 6.11. Technical success rates vary from 68% to 98%, with success rates higher in patients with lower BMI or altered surgical anatomy, such as Billroth I and II procedures where the duodenum and proximal jejunum are brought out into the peritoneal space. Point 139-142 Successful placement is facilitated by having an experienced two-person team, one a scope person, one a skin person, avoiding insufflation of the stomach, looking for transillumination immediately after passing below the ligament of Treitz, and using a 22-gauge spinal needle to puncture the small bowel. Snaring the 22-gauge sounding needle helps hold the small bowel in place while the trocar can be passed at the same angle and site. Once the snare is transferred to the trocar, the rest of the procedure is virtually identical to the Ponsky pull technique for peg placement. The Sachs-Vine push and the Russell introducer techniques should not be used for this procedure. Management of the DPEJ tube is likewise similar to that of peg tubes. Complications. Most post-PEG complications arise from a patient's comorbidities, such as poor wound healing, aspiration, or coagulopathy. To reduce the risk of aspiration, caregivers should raise the head of the patient's bed 30 to 45 degrees during feeding and for 1 hour afterward. 1051 Common complication of PEG is peristomal wound infection. 143 Risk factors for peristomal infection include diabetes, obesity, malnutrition, chronic glucocorticoid use, small incisions at the PEG insertion site, lack of antibiotic prophylaxis, and excessive pressure of the external bumper on the PEG site. 144 Excessive tightening of the PEG. Tube external bolster against the abdominal wall can cause buried bumper syndrome, BBS, Fig 6.12, which in turn can lead to mucosal ulceration, bleeding, stomal leakage, peristomal infection, and even necrotizing fasciitis. 145 To minimize the chance for BBS, the external bolster of the PEG tube should be maintained up against the skin, without indentation, for 4 days post-placement, after which it should be carefully moved back 1 cm from the anterior abdominal wall. 145 Peristomal wound. Infections are often treated for 7 days with an oral antibiotic such as cephalexin to cover skin-related microorganisms. The infected area should also have daily topical cleansing with mild soap and water. Yeast colonization of the silicone PEG can lead to degradation and loss of tube integrity, requiring timely replacement. 146 Clogged PEG tubes may be cleared by flushing with warm water, soft drinks, or a slurry of pancreatic enzymes mixed in a bicarbonate solution. 147 Mechanical declogating with a wire, specimen brush, endoscopic cleaning brush, or commercially available corkscrew declogating device may be required in some cases. Excessive growth of granulation tissue around the PEG tract represents an exuberant response to the wound injury. Topical silver nitrate can be applied to compress, cauterize, and remove excess granulation tissue at the gastrostomy site. 148 Other common complications include peristomal leakage, fever, ileus, cutaneous ulceration, and tube dislodgement. 149-151 Leakage around the gastrostomy site is a common and under-recognized problem. Risk factors for peristomal leakage include the use of glucocorticoids, chemotherapy, excessive cleaning with hydrogen peroxide or iodine, excessive tension and side torsion of the tube, and absence of an external bumper. Leakage of gastric acid or bile around the PEG tube can cause erythema and skin breakdown that is often mistaken for infection. Treatment includes keeping the site dry with frequent dressing changes, topical zinc oxide, maintaining the external bumper 1 cm from the skin, stabilizing the gastrostomy tube with a vertical clamping device, and the use of PPIs. 62,144 Pneumoperitoneum is common after PEG placement and is of no concern in the absence of peritoneal signs. Any signs of peritoneal irritation should prompt an investigation with a contrast study through the PEG tube to determine presence or absence of a leak. Confirmation of a leak should lead to surgical exploration. 152 Major complications are rare and include intra-abdominal bleeding or hematoma formation, peritonitis, necrotizing fasciitis, gastric or colonic perforation, and hepatogastric, gastrocolic, and colocutaneous fistula formation. A colocutaneous fistula results. Fig 6.11 Direct percutaneous endoscopic jejunostomy sounding needle insertion and snare fixation in the 2-needle stick technique. Fig 6.12 Buried bumper syndrome. Chapter 6 Nutritional Management 87.6 From inadvertent placement of a percutaneous feeding tube through the colon before it enters the stomach. While sometimes acute, the usual presentation is more chronic and may be suspected if stool is seen around the PEG tube or the patient develops diarrhea immediately upon feeding through the PEG tube. If a PEG tube becomes dislodged within 7 days of placement, the patient should be brought back to the endoscopy suite and a new PEG placed through the same site on the anterior abdominal wall. It is not necessary, or perhaps even possible, to pass through the same exact site in the gastric wall, because if close to the original site, cinching of the new bolsters and the cross configuration of the muscular layers of the gastric wall help seal the original entry tract. Such patients may benefit from a short course of a broad-spectrum antibiotic. If the PEG tube becomes dislodged more than 4 weeks after placement, the tract should be mature enough to blindly replace the PEG tube at the bedside without fluoroscopic or endoscopic monitoring. Proper placement should be confirmed with a contrast radiologic study through the PEG tube prior to using the tube for feedings. With PEGJ tubes, the jejunal tube may migrate in a retrograde direction or become kinked so that it no longer functions. More than 50% of PEGJ tubes require re-intervention within 6 months. 153 Tube migration occurs most commonly in patients who have persistent vomiting or in cases where the J tube has been placed improperly. 137,154 Other factors for tube migration include failure to cut the PEG tube down to a short enough length, 10 cm, shortened length of the jejunal tube, and placement of the PEG tube too high in the body or fundus, causing the jejunal tube to loop in the stomach. Placing the PEG tube in the antrum, avoidance of looping the jejunal tube in the stomach, and securing the distal end of the jejunal tube with a hemoclip can prevent proximal migration. 144 Enteral feeding patients may receive their tube feedings by bolus, intermittent, or continuous methods. Bolus feeding delivery allows a relatively large volume of tube feeding, 200 to 400 ml, to be delivered over a short period of time by a syringe. Intermittent feedings are delivered over a few hours by pump or by gravity drip using a bedside pole. Continuous feedings are usually delivered over 12 to 24 hours by a mechanical pump. Patients who receive small bowel feedings are almost always fed using continuous feedings. An intermittent or continuous feeding regimen, rather than the rapid bolus method, may be used to limit the risk of tube feeding aspiration. Tolerance of enteral feeding should be monitored by assessing for complaints of abdominal pain or distension, symptoms of nausea and vomiting, passage of flatus and stool, and dilated loops of bowel or air/fluid levels on abdominal imaging. Gastric residual volume, GRV, does not correlate well with the incidence of regurgitation, aspiration, or pneumonia, and are a poor measure of gastric emptying. Checking routinely for GRV is no longer recommended. Measures to reduce the risk of aspiration include keeping the head of the bed elevated 30 to 45 degrees in intubated ICU patients, changing from bolus to continuous infusion, using promodality drugs, e.g., metoclopramide or erythromycin, or narcotic antagonists, naloxone or alvimopin, and converting the level of infusion from gastric to post-caloric. Enteral formulations. Standard polymeric formulations are lactose-free and gluten-free, and are the basic feeding formulas designed for long-term use in hospitalized adult patients. These formulations are denoted as polymeric because the macronutrient components are intact and not pre-digested. Standard formulations contain 15% to 20% calories from proteins, 45% to 60% calories from carbohydrates, and 30% to 40% calories from fats. Generally, these formulations provide 1 kcal/ml, although they may be concentrated to 1.5 to 2.0 kcal/ml. As the calorie content per milliliter volume of tube feeding increases, the free water content of the formula decreases and the osmolarity increases. Most enteral formulas contain close to 80% free water. Formulas that are higher in protein are designated as high nitrogen, HN, formulas. Elemental formulas contain protein in the form of free amino acids and are nearly fat-free, i.e., less than 2% to 3% of the caloric content is fat. Semi-elemental formulas contain protein in the form of small-chain peptides, predominantly of 3 to 5 amino acids in length. Protein absorption is more efficient, as the small peptide chains can be transported across the intestinal wall intact by a single active transporter, rather than requiring a separate transporter for each amino acid, see Chapter 102. Fat is in the form of MCT, which can be absorbed directly into the portal vein without lipase, colipase, or bile salt transportation, see Chapter 102. The semi-elemental small peptide/MCT oil formulations have largely supplanted the original elemental formulas, and are designed for patients with limited digestive capacity. While physiologic studies support greater absorption of the semi-elemental formulas than intact polymeric formulas in situations of compromised bowel function, clinical RCTs show little difference in outcome parameters. Specialty organ-specific or disease-specific formulations are designed for patients with certain disease processes, such as diabetes, renal failure, hepatic failure, pulmonary disease, severe stress, or trauma. There are little or no data to show that these specialty formulations improve survival, or give any advantage with regard to clinical outcomes, compared with standard polymeric formulas when used for their intended disease states. Inadvertent use occurs usually for reasons involving their electrolyte profile, being low in potassium and phosphorus, renal formulas, or sodium, hepatic formulas. Protein should not be restricted in patients with either hepatic or renal failure. Immune-modulating formulas are supplemented with arginine, glutamine, omega-3 fatty acids, antioxidants, and nucleotides, substances shown to be important in immune modulation. Arginine is needed for cell growth and proliferation, wound healing, nitric oxide production, and lymphocyte differentiation. Arginine requirements increase in critical illness, and supplementation may facilitate wound healing. 155 Fish oil may help in reducing systemic inflammation. Patients most likely to show a benefit from arginine fish oil. Immune-enhancing formulas include those undergoing elective GI surgery and those post-operative patients in the surgical ICU requiring EN therapy. Use of immune-modulating formulas in these patients reduces infectious complications, antibiotic needs, duration of mechanical ventilation, multiple organ dysfunction, and hospital stay. 156 While use of such formulas in a medical ICU patient is safe, current data show lack of efficacy in changing clinical outcomes. Similarly, use of a fish oil, antioxidant-containing, anti-inflammatory formula in patients with acute lung injury or acute respiratory distress syndrome cannot be recommended for reasons of safety and lack of efficacy. Complications of enteral feeding. GI side effects of tube feedings are reported in 15% to 30% of patients, and include nausea, vomiting, abdominal distension, abdominal cramping, and diarrhea. Diarrhea is most commonly due to medications and less often to Clostridioides difficile enterocolitis, see Chapter 112. Medications can be altered from tablet to liquid form for easy installation through the feeding tube, by dissolution in a sorbitol base, a known cathartic. Magnesium-containing medications, hypertonic medications, and promodality agents may also promote diarrhea. High osmolarity and formulations, even with an osmolarity as high as 600 to 700 mosm/L, are rarely a cause of diarrhea. In a patient with new-onset diarrhea who was previously tolerant to an enteral formula, the patient should be assessed for medication-induced and infectious etiologies prior. 88 Part 2 Nutrition in Gastroenterology to changing the formula. There are no data to support dilution of the enteral formulation to improve GI tolerance. For patients with compromised bowel function, use of the semi-elemental formulas may improve absorption and reduce diarrhea. Soluble fiber supplementation or use of a commercial mixed soluble/insoluble fiber formula may improve diarrhea as well. 157,158 Metabolic complications are less common with EN than with PN feeding. Dehydration and fluid shifts may occur with formulas of high concentration, especially if insufficient water is supplied. Hyperglycemia may occur with high rates of carbohydrate delivery in patients with glucose intolerance. Medication delivery may also be affected by concurrent tube feeding. Phenytoin administration is affected, because the drug binds to the enteral formula and forms a phenytoin tube feeding complex that adheres to the wall of the feeding tube. 159 Ciprofloxacin has also been shown to bind with tube feedings, reducing its absorption. Vitamin K, present in many enteral formulas, will make a patient more resistant to the effects of warfarin. Parenteral nutrition for patients with a non-functioning GI tract, nutrients can be delivered directly into the venous system via PN. PN delivers a solution comprising macronutrients, carbohydrates, proteins, lipids, micronutrients, vitamins, minerals, trace elements, water, electrolytes, and medications. Carbohydrates are delivered as dextrose, proteins as amino acids, and lipids as 4-fat emulsions, IVFEs. When all three macronutrients are combined into a single solution, it is referred to as a total nutrient admixture or 3-in-1 solution. When IVFEs are given separately, the PN formula is referred to as a 2-in-1 solution. Nutrients can be delivered into a central vein, central PN, or a peripheral vein, peripheral PN/PPN. Use of PPN is restricted or prohibited in most hospital settings, because of the likelihood for abuse of the indications for PPN, and for sclerosing the veins despite keeping the osmolarity below 800 to 900 mosm/L, which in turn leads to short-term duration of therapy of usually 12 to 36 hours. PN is usually delivered over 12 to 24 hours. A PN solution is 6 times more concentrated than blood, 1,800 to 2,400 mosm/L, and generally consists of approximately 30 to 50 g/L of protein and 1000 to 1200 kcal/L. Parenteral nutrition formulation. To create a PN formula, one must first determine the caloric and protein needs of the patient, which are based on a prior nutritional assessment. See Chapter 5.160. Protein and calorie needs increase with increasing metabolic stress, except in the critically ill. Each component of PN has a defined caloric content, with protein equals 4 kcal/g, carbohydrate, dextrose, equals 3.4 kcal/g, and IVFE equals 10 kcal/g, 9 kcal/g from fat, 1 kcal/g from emulsifier. Protein needs vary in the range of 1.2 to 2.0 g/kg/day depending on the level of metabolic stress. Protein should not be restricted, even in patients with severe hepatic encephalopathy or renal failure with azotemia requiring imminent dialysis. Fat is usually provided at 1 g/kg/day, but may need to be reduced or restricted for patients with hypertriglyceridemia, greater than 400 mg/dl. Despite fat restriction, a minimal amount of fat is still given, usually 10% of estimated fat calories, or 500 ml of 20% intralipid per week, to prevent essential fatty acid deficiency. The remainder of a patient's daily energy requirements is administered in the form of dextrose. To prevent hyperglycemia and refeeding syndrome, see later under metabolic complications, the amount of dextrose should initially not exceed 200 Guaranese. Dextrose should be titrated over the course of several days to the goal amount. Water is added to meet the patient's daily volume needs, with fluid volume restricted in patients with fluid overload, cardiopulmonary disease, or renal failure. Overall water requirements are estimated at 25 to 35 ml/kg/day. Once the macronutrient components of a PN formula have been defined, electrolytes, trace elements, multivitamins, and medications like insulin, heparin, and PPIs or H2BS can be added. Any of the components can be increased or decreased based on a patient's laboratory values and comorbid disease processes. For patients in an unmonitored non-ICU setting, potassium in the PN formula should not exceed 10 milliequivalent/Hr. The amount of calcium and phosphorus in the PN solution must also be monitored, owing to the risk of precipitation of calcium phosphate crystals. In general, the calcium phosphorus sum, milliequivalent of calcium and mol of phosphorus/L, should be less than 45 to prevent precipitation. Vitamins and trace elements are added using preset solutions, but additional supplementation can be added based on documented needs. Because copper and manganese are excreted in bile, these minerals should be withheld in patients with cholestasis. Selenium should be decreased in patients with renal insufficiency, whereas zinc should be increased in patients with diarrhea, high-output fistulas, or large wounds. 161 Moderate glycemic control is recommended, keeping serum glucose levels between 110 and 150 mg/dl by sliding scale coverage or addition of insulin to the solution. 61 A sample stepwise approach to writing a central PN order is shown in box 6.1. Administration. At initiation, the PN formula should be infused over 24 hours. Patients with glucose intolerance or those at risk for refeeding syndrome, see later discussion of metabolic complications, should have their PN infused at 25% of their daily caloric needs for the first 24 hours. This ratio may be increased to full caloric needs over the following 48 to 72 hours, with monitoring of serum levels of glucose, magnesium, potassium, and phosphate, as well as fluid tolerance. 162 PN is infused via a large central vein. The port or lumen of the catheter utilized for PN must be used solely for PN infusion. Use of the PN port or lumen for blood drawing or infusion of other solutions increases the risk of catheter infection. Box 6.1 Stepwise approach to writing a parenteral nutrition order for a 70 kg man. Caloric contents of nutrient substances: protein, 4 kcal/g fat, 10 kcal/g carbohydrates, 3.4 kcal/g. Estimated daily needs for this patient: calories, 25 kcal/kg equals 1750 kilocalories. Protein, 1.2 g/kg equals 84 grams fluids, 30 ml/kg equals 2100 ml. Steps 1. Add protein, 1.2 g/kg/day, to the PN mixture. 84 grams of protein needed. 1 gram of protein equals 4 kilocalories, total, 326 kilocalories, 1750 kcal. 326 kcal equals 1424 kilocalories still required. 2. Add lipids, 1 to 1.5 g/kg/day. 70 grams fat equals 700 kilocalories. 1424 residual calories. 700 kcal equals 724 kilocalories still required. 3. Add carbohydrates, 3 to 5 g/kg/day. 724 kcal/3.4 kcal/g carbohydrate equals 212.9 grams. 4. Make total volume. 30 ml/kg equals 2100 ml. Additional additives: electrolytes, minerals, vitamins, drug additives, H2RAS, insulin, heparin. Chapter 6 Nutritional Management 89.6 Laboratory testing. Following PN initiation, certain serologic values must be monitored. In the first few days following initiation of PN infusion, serum concentrations of electrolytes, magnesium, phosphorus, calcium, potassium, and blood urea nitrogen, BUN, should be monitored closely. After stabilization, these values can be checked weekly. In the home PN, HPN, patient on long-term infusion, checking these routine laboratory tests is decreased in frequency to once per month. Complete blood cell counts should be performed monthly. In other clinically relevant cases, serum zinc, selenium, copper, chromium, vitamin B1-2, and vitamin B6 levels may have to be monitored. Because iron is not a standard additive for PN solutions, patients who are PN dependent require monitoring for the development of iron deficiency anemia. Metabolic complications. Metabolic complications may develop as a consequence of the glucose, amino acid, lipid, vitamin, electrolyte, or mineral content of the PN solution. 163 Hyperglycemia is the most common complication and is directly related to PN dextrose content, the patient's insulin sensitivity, and the rate of PN infusion. Critically ill patients and those with pre-existing glucose intolerance require the most aggressive serum glucose monitoring. Patients who develop hyperglycemia should first be maintained on a sliding scale of regular insulin. Of the total amount of sliding scale insulin required over 24 hours, 2/3 should be added to the next day's PN formula. Further adjustments in insulin dosing may be required on a daily basis, and some patients in the ICU may require a separate insulin drip. Failure to control blood glucose levels results in an increase of infectious complications, such as catheter sepsis. In some hospitalized patients, blood glucose control may be difficult even with an insulin drip, and permissive underfeeding can be performed. In these patients, the risk of hyperglycemia and its consequences is greater than the risk of temporarily underfeeding the patient. Refeeding syndrome is a metabolic consequence of nutrition support resulting from sudden provision of a large amount of glucose calories to a patient who was previously malnourished. With nutrient infusion, the metabolism of these patients rapidly becomes anabolic. Insulin production is increased, pushing potassium, phosphorus, magnesium, and thiamine into the intracellular space, with resultant hypokalemia, hypophosphatemia, and hypomagnesemia. 164 Sodium retention and large fluid shifts can also occur and may place the patient at risk of developing heart failure, in addition to neurologic sequelae. 165 Sudden shifts in serum electrolytes may precipitate cardiac dysrhythmias. To prevent refeeding syndrome, the initial caloric content should be limited and the macronutrients gradually titrated, particularly dextrose, from 25% up to 80% to 100% of energy goals over 3 to 4 days, while electrolytes are carefully monitored and corrected as needed. While refeeding syndrome may be precipitated by N or PN, risk is greater with provision of N. Abnormal liver enzymes are common after initiation of PN and typically feature elevations of serum aminotransferase levels up to twice normal. Greater elevations in aminotransferase levels and associated hyperbilirubinemia warrant investigation. PN can lead to 3 types of PN-associated hepatobiliary disease: steatosis, cholestasis, and gallbladder sludge/stones. Other causes of underlying liver disease should be excluded. Use of the RUQ helps to exclude dilated bile ducts, presence of a liver mass, cholelithiasis, or biliary sludge. Lack of enteral stimulation results in decreased CCK release, with impaired bile flow and gallbladder contractility. Gallbladder stasis can lead to development of gallstones or gallbladder sludge, resulting in both calculous and acalculous cholecystitis. PN-associated steatosis presents as a fatty infiltration of the liver that is especially prominent in the periportal areas. Patients with PN-associated steatosis have modest elevations of serum aminotransferases that usually occur within 2 weeks of starting PN and may return to normal with time. Most patients with PN-associated steatosis are asymptomatic. The condition appears to be secondary to overfeeding and may respond to a reduction in the patient's total daily caloric infusion. 166 PN-associated cholestasis is a condition of impaired bile secretion that occurs predominantly in children and presents as an elevation of alkaline phosphatase, GGTP, and bilirubin. In a small percentage of patients on HPN, long-term PN-associated cholestasis may progress to cirrhosis and liver failure. Repeated episodes of catheter sepsis may contribute to the probability of PN-induced liver injury. Bacterial and fungal infections are associated with cholestasis. SIBO is another risk factor for liver disease, most likely caused by the production of alcohol through fermentation or hepatotoxins by anaerobic bacteria. 62 Choline deficiency may play a role in the development of liver disease associated with long-term PN. 167. The lipid source also is believed to contribute to this complication. In the USA, the lipid content of the PN solution is soy-based and composed mainly of long-chain triglycerides, e.g., linoleic acid, an omega-6 fatty acid, which are pro-inflammatory. Phytosterols and stanols in this lipid source may be hepatotoxic in some patients. Unlike soy-based long-chain triglycerides, MCT oil and olive oil are essentially devoid of pro-inflammatory properties. Fish oil, which is rich in omega-3 fatty acids, has anti-inflammatory properties. IVFEs with medium-chain triglycerides, olive oil, and fish oil are available in this country. Fish oils have been shown to be effective in reversing PN-induced liver disease in prospective and retrospective studies in children. 168 In an adult receiving PN who develops elevated liver biochemical tests, appropriate management strategies include cycling the PN regimen over 12 to 18 hours each day, performing indirect calorimetry to confirm energy requirements and readjusting to avoid overfeeding, and switching the soy-based intralipid IVFE to a mixture of lipids, SMOF containing soy, MCTs, olive, and fish oils. Patients who develop significant complications with PN use may be candidates for small bowel transplantation, see Chapter 106. These complications include progressive liver failure, repeated catheter sepsis, or thrombosis of major venous systems. AB Fig 6.13 Commercial and homemade air valves. A. The top figure shows a commercial air valve passed over the guide wire, which is used most often during PEGJ conversion. B. A homemade air valve may be created by cutting off the valve plug on a feeding tube, coring the valve out with a pair of scissors, and then passing a snare or wire through the valve. Reprinted with permission from Chandra C. Karavi, Kochman M. Techniques in Gastrointestinal Endoscopy, Elsevier. 90 Part 2 Nutrition in Gastroenterology that precludes obtaining central venous access. Current 5-year survival rates for patients receiving small bowel transplants are close to 50%. 169 But the 5-year survival rate of patients on HPN are still better than the 5-year survival rate for patients receiving small bowel transplants. Quality of life differences between HPN and small bowel transplantation are still being explored. Vascular access devices. Anatomically, the subclavian and internal jugular veins provide the safest and easiest central venous access. Compared with other central venous access sites, the subclavian vein is often chosen for long-term access, because of reduced catheter-associated complications. Multi-lumen catheters allow for infusion of a number of fluids and medications at the same time, but risk of infection increases with an increasing number of lumens. 170,171 single-lumen catheters are preferred unless multiple ports are necessary for patient management. If a multi-lumen catheter is used, one lumen should be designated for only PN use. 172 There are three types of central venous catheters, CVC, available for PN infusion: peripherally inserted central catheter, PIC, tunneled indwelling CVC, Hickman, Broviac, or Grosjean catheters, and implantable vascular access device or port. PIC lines have been used for PN infusion both in the hospital and at home. The PIC line is generally placed in an upper extremity, with the tip of the catheter positioned in a central vein at the junction of the superior vena cava and the right atrium. PIC lines are associated with a reduction in major insertion complications, e.g., pneumothorax, compared with previously standard centrally inserted catheters. PIC lines should only be utilized for patients with anticipated short-term needs for PN. PIC lines are not appropriate for long-term use as they only remain patent for a maximum of 1 to 2 months and may promote venous sclerosis. Tunneled indwelling CVCs are commonly used when a catheter is required for longer than 1 to 3 months. Indwelling catheters are tunneled subcutaneously, creating a physical barrier to bacterial infection. They have a Dacron cuff to induce tissue ingrowth and local fibrosis, thereby anchoring the catheter. This prevents accidental dislodgement and is believed to prevent bacterial migration up the catheter. 173 The catheter tip should be positioned in the distal third of the subclavian vein. Implantable ports are placed subcutaneously, usually on the chest wall, and by eliminating the external catheter portion, daily heparin flushes are unnecessary. Implantable ports require a specialized access needle to allow blood drawing or fluid infusion and have a limited lifetime of punctures. They also require a more extensive procedure for bedside removal than tunneled catheters. Single-lumen PIC lines and implantable ports have a lower incidence of catheter-related bloodstream infections, CRBZ 0/1000 and 0.19/1000 catheter days, respectively, compared with tunneled, 0.64/1000 catheter days, and non-tunneled CVCs, 0.87/1000 catheter days. Single-lumen PIC lines and implantable ports also have been shown to have a longer failure-free duration because of fewer mechanical complications, 13.9% and 9.7%, respectively, than non-tunneled catheters, 17.8%. 174 Central venous catheter complications. CVC complications occur in an incidence range of 1% to 20%. 175 Complications of subclavian vein catheter placement include hemothorax, pneumothorax, brachial plexus injury, hematoma, and subcutaneous emphysema. Common long-term catheter complications include sepsis, thrombosis, and catheter occlusion. Catheter breakage, dislodgement, and air emboli also can occur. Catheter infection generally occurs from touch contamination. The predominant organism isolated is coagulase-negative Staphylococcus. Other organisms include resistant strains of gram-positive cocci, e.g., Staphylococcus aureus, Enterococcus species, Streptococcus species, gram-negative bacilli, e.g., Klebsiella pneumoniae, Escherichia coli, Enterobacter cloacae, and fungi, e.g., Candida parasilosis, Candida albicans, Candida glabrata. 176,177 The major mechanism of catheter contamination is tracking of organisms from the skin to the subcutaneous tissues and catheter tip. In the home setting, the more time spent teaching the patient about the care and operation of the central venous access device, the less likely the patient is to develop infectious complications. 178 Diagnosing catheter infections can be difficult because the white blood cell count may not be elevated if a patient is immunocompromised, and peripheral blood cultures can be negative. Catheter tip culture is a much more sensitive method of documenting catheter infections. Generally, bacterial infections of catheters can be treated with the catheter in place, whereas fungal catheter infections and tunnel infections of the catheter tract require catheter removal for effective treatment. It is common for broad-spectrum antibiotic or antifungal treatment of catheter infections to be initiated once the diagnosis is suspected, and definitive therapy is introduced when the organism is identified. Addition of heparin, 1000 units/L, to each bag of PN solution can prevent subclinical thrombus formation to which bacteria or fungi can attach, thereby potentially reducing the risk of catheter sepsis. Routine use of anticoagulant therapy to reduce the risk of catheter-related infection, however, is not recommended. 179 When treating CVC infections, importance is given to the actual contact time between the bacteria or fungus in the catheter and the antibiotic or antifungal agent. Locking the antibiotic into an infected line, at the end of each infusion, may help reduce central line decontamination. 180 Others advocate flushing the catheter daily with pharmaceutical-grade 50% to 70% ethanol to sterilize the catheter and reduce infectious events. 181 The use of catheter locks has been shown to reduce the risk of corruption. Antibiotic lock therapy has been shown to decrease the incidence of recurrent corruption. Ethanol has both bactericidal and fungicidal properties, and has a low risk for causing antimicrobial resistance. One RCT which sought to assess the generalizability of this practice randomized 38 patients newly started on HPN to either treatment with ethanol lock therapy or to standard of care with heparin locks. 182 4 patients in the ethanol lock therapy group and 1 patient in the control arm developed a corruption. Thus, use of prophylactic antimicrobial and ethanol lock solutions is usually recommended for those who have a history of multiple CRBSIs but has not shown benefit when applied to all patients newly started on HPN. Of note, ethanol locks should only be used in silicone Hickman catheters and cannot be used in polyurethane catheters. Catheter-induced thrombosis occurs secondary to irritation of the blood vessel wall. The thrombus usually is composed of fibrin. Precipitation of medication in the catheter occurs less commonly. Symptoms of central vein thrombus formation include neck pain, neck swelling, anterior chest wall venous distension, and reduced catheter function. Flushing the CVC with saline has proved as beneficial as flushing with heparin for preventing catheter occlusion by a thrombus. 183 Treatment of fibrin thrombus formation requires a thrombolytic agent like streptokinase, given as a bolus or continuous infusion. 184 Medication or precipitate occlusions can be treated by instilling small amounts of sodium hydroxide or hydrochloric acid, depending on whether the drug is acidic or basic, respectively. 185 Special diets. Clear liquid diets supply fluid and energy in a form that creates a minimal amount of residue. They are meant to avoid the high osmolar delivery of nutrients to the GI tract, which would result in fluid shifts and associated nausea and diarrhea. Clear liquid diets generally contain an abundance of carbohydrates but little protein or fat and are thereby nutritionally. Chapter 6 Nutritional Management 91-6 Inadequate to meet basic metabolic needs. Little evidence suggests that a clear liquid diet is better tolerated than any other diet in the postoperative period. Where possible, clear liquid diets should not be prescribed, as there is no physiologic rationale for their use. They tend to be high in sodium content, and their provision cannot be justified other than fulfilling a patient's personal wishes. In contrast, early N feeding after abdominal or thoracic surgery may reduce postoperative complications, hospital length of stay, and mortality, although vomiting may be increased. 186-187 Full liquid diets are indicated for patients who are unable to chew, swallow, or digest solids. They are largely milk-based and should not be used for lactose-intolerant patients. They contain a large amount of simple carbohydrates and should be used with caution in diabetic patients. Low-fiber, low-residue diets are used for patients with GI strictures as well as those with gastroparesis and are presumed to reduce the risk of obstruction while prolonging transit time. Carbohydrate intake is reduced, and well-cooked vegetables, refined cereals, and breads are used instead. For gastroparesis, low-fat intake is also recommended. High-fiber diets include soluble and insoluble fibers, which have a wide range of metabolic and physiologic effects. They are used to reduce intraluminal colon pressures in patients with diverticulosis. They may also be useful in diabetes by delaying glucose absorption, and in cardiovascular disease by lowering serum cholesterol and serum triglyceride levels. Lifelong high-fiber diets may help prevent colon cancer. A high-fiber diet emphasizes foods such as vegetables, fruits, legumes, and whole-grain breads and cereals. A post-gastrectomy or anti-dumping diet involves ingestion of small, frequent meals high in protein and fat, to deliver a lower osmolarity solution to the small intestine. Simple sugars are avoided to prevent their rapid absorption. 188 Fluid intake should be restricted and separated from solid food intake to avoid rapid gastric transit. High pectin-containing foods, such as bananas and oranges, are included in this diet to slow gastric output. Low-fat diets are used to minimize diarrhea and steatorrhea associated with fat malabsorption, especially in patients with pancreatic or biliary dysfunction. In those patients placed on a low-fat diet for a prolonged period of time, fat-soluble vitamins, A, D, E, K, must be supplemented. MCT oil may be used to substitute for long-chain triglycerides. MCTs have 6 to 12 carbon fatty acid chains, high aqueous solubility, and do not require bile salts for absorption in the small intestine. 189 MCTs do not require chylomicron formation and are absorbed directly into the portal venous system. Unfortunately, most MCT-based products are not very palatable. Many MCT-based products such as regular flavored semi-elemental formula with MCT oil and small-chain peptides can have a medicinal taste. Vanilla-flavored versions of these formulas with or without flavor packets increase palatability. The nature of training for the gastroenterologist provides the skill set to perform as a clinical nutritionist. Appropriate knowledge and clinical applications of nutritional issues are important requirements for management of most patients with GI disorders. Having the skills to achieve enteral access, the ability to achieve GI tolerance to enteral feeding, and an understanding of metabolic to illness or injury is integral to good patient care.